Well, good afternoon, everyone. Welcome to our webinar, Antibiotic Stewardship in Production Animal Settings. This event is brought to you by Wisenetics. I am Brandy Buzzard, one of the hosts of the Beef Podcast Show and a Kansas rancher, and I will be your host today. Today's topic is of utmost importance for our industry, antibiotic stewardship. The use of antibiotics in food-producing animals has become a major concern due to its alleged connection with the development of antibiotic resistance in humans and animals. So the goal of antibiotic stewardship is to minimize such practices while maintaining health and welfare. With that in mind, what do we still need to learn about antibiotic stewardship in beef production? To talk about that today, we are very pleased to have a great reference on the subject, Dr. Brian Lubbers, Associate Professor of Food Animal Therapeutics at Kansas State University. Dr. Lubbers is an associate professor of food animal therapeutics at Kansas State University, having earned his PhD in microbiology at KSU. His teaching and research interests are antimicrobial stewardship and therapy, along with antimicrobial resistance and application of diagnostic testing in food animals. First of all, I'd like to begin by thanking our guest, Dr. Lubbers, for being here today. Dr. Lubbers, your presence is very much appreciated and crucial to our industry, and I'm sure the wealth of knowledge you'll share today will be invaluable to everyone tuning in. So thank you very much for coming. And to our audience, I want to thank you all for participating in the webinar today, and thank you for your presence, time, and trust. Please feel free to join in and participate as much as you'd like. I know there may be questions during the presentation, so I encourage you to write them in the chat as you come to mind, and then we will get to those and answer those at the end. So without further ado, let's get down to business and welcome Dr. Lubbers to the platform.
Brandy, really appreciate the opportunity to be here with everyone today. And as you mentioned, thanks for the kind introduction. I'm going to talk about antibiotic stewardship in production settings. And so I wanted to start with this. So I kind of want the audience, and actually I'd appreciate it if people would put in the chat, and we won't necessarily visit it right now, but I'm going to commit you to some answers here. So help me understand when somebody says stewardship to you, what does that mean? And the reason I ask this is because I think it's kind of the first step as we talk about antibiotic stewardship in production settings and really in any setting. We have to be talking about the same thing. And so whether it's me talking to producers or me talking to veterinarians or producers talking to consumers, however that goes, we kind of need to start with that common language. And just to give you a couple examples, so I asked my students here at Kansas State, I asked them this question, and these are third-year veterinary students, right? They should have a pretty good idea of what antibiotic stewardship is. And this is the word cloud from the class a couple years ago. And what I take out of this is that there are some strong common themes that we can all agree on when we talk about stewardship. But when we get kind of to the edges, and the edges are important because that's kind of what defines the details of how I'm going to act on a day-to-day basis, that those edges get a little bit fuzzy. And you can see here, my students, they talk about responsible use, they talk about appropriate use, but then they talk about some of the ancillary diagnostic tests that are used. They talk about making science-based decisions. They talk about what their prescribing practices or maybe even their ethics with that use will be. And so what I want to do is I want to take you through, and this isn't unique to veterinary students or veterinary settings. Actually, this is a common theme even in the human medical community. And so what I have here, and it's not just human, I've put the veterinary definition here as well, but what I have are, these are the definitions of stewardship. The top one is from the Infectious Disease Society of America. So those are human physicians that are dealing with very sick patients in a hospital setting. In their situation, most of those physicians will have the patient's already been diagnosed with a severe bacterial infection. And so those are the people that get called in to help manage that severe bacterial infection. And you can see from their definition, their definition of stewardship really focuses on the optimal use of a drug and how we're going to dose it, how long we're going to give it, what route of administration we're going to use. Then if we go to, so the CDC, the Centers for Disease Control, they have an outpatient antibiotic stewardship guideline. And this is meant for human physicians that would be like your general practitioner, somebody you would go see if you got sick or you had a small cut or whatever. And they have some common themes there as well, right? So they want to measure use, they want to improve prescribing. But if you get into their definition, they're also worried about things like minimizing misdiagnoses or delayed diagnoses. And they talk actually about underuse of antibiotics with antibiotic stewardship. And you think about those two groups. So an infectious disease physician, they said their patients probably, there's a high probability that they've already been diagnosed with a bacterial infection. But with the CDC guidelines tailored towards general practitioners, they have to work through the diagnosis. And give the example, in the wintertime and somebody has a cough and maybe some sinus congestion, that physician has to figure out, is that a viral infection where an antibiotic probably wouldn't be appropriate, or am I progressing into a disease where I have a bacterial infection and it's severe enough that I think there would be a negative clinical outcome if I didn't prescribe those antibiotics. So you can see just even two different subsets of human physicians, they have slightly different degrees of definitions of antibiotic stewardship. And then when we go to the AVMA, this is the American Veterinary Medical Association. So their definition of stewardship for the veterinary profession, it takes on it's a very big picture definition if you read it. And so you think about the AVMA and who their constituents are. Those are veterinarians, but veterinarians are in a lot of different types of practice settings, right? We have everything from practitioners that focus solely on small exotic pocket pets, rats, rodents, snakes, pets, to kind of small animal, what we consider kind of traditional small animal exclusive practitioners, to mixed animal practitioners who deal with all different species. And then we have exclusively food animal practitioners, and they all certainly have different disease challenges that they're worried about. They have a different clientele set, and so all of those things matter. And so from the AVMA's perspective, they have to try to come up with a definition of stewardship that is applicable to all of those scenarios, and it's a huge challenge. And so obviously stewardship is it's kind of a passionate topic for me, obviously. So this is my definition of stewardship, and this is something that in working with consumers, producers, veterinarians over the years, I've kind of tended to refine this a little bit. But if you think about where those two black lines meet, kind of in the center of the screen, that's the point where we need to use an antimicrobial. And so you can kind of break stewardship down into the actions around, and again, I take this from a very case specific situation. It's the AVMA's definition is very broad. I look at stewardship from the perspective of the individual veterinarian, or if we think about production settings where the veterinarian and the producer work together to make that decision, because all of these other factors will come into play that determines, is that a good stewardship decision or a not good stewardship decision. And so there are activities in all of these quadrants that we can think about that actually are stewardship activities or antibiotic stewardship activities. So let's start up here in the upper left. So those are the things I do before an animal gets sick, and then I've classified that as prevention practices. So things I'm going to do to actually prevent disease. And somebody might say, well, how is disease prevention antimicrobial stewardship? And I guess my short and easy answer is, if I if I do things that are management practices that put an animal in a situation where it never needs an antibiotic, that's probably the best antimicrobial stewardship. So I think about disease prevention practices or things, we think about vaccination protocols, we think about nutrition programs, we think about parasite control, we think about environmental management, we think about all of those things because in some way, shape, or form, they either directly reduce the pressure of bacterial disease or they increase the immunity of an individual animal so that that can handle a more robust disease challenge. So I definitely think that disease prevention practices should fit into our definition of antimicrobial stewardship. So let's go to the lower left quadrant. And this is typically when I talk to producer audiences about antibiotic stewardship, how do they define antibiotic stewardship? I get this quadrant very heavily focused. So they say something like, well, we use antibiotics judiciously, or we select the most appropriate antibiotic for that particular disease challenge. And certainly that is an aspect of antimicrobial stewardship. Um, we want to make sure that we're using the right antimicrobial for that specific disease challenge. We have layers of things we can do to do that right. It might be based on working with our veterinarian to say this is our primary disease challenge, and these are antimicrobials that have activity against those bacteria, and these are antimicrobials that don't have activity, and we make sure we don't use those antimicrobials for that disease challenge, because just like disease prevention practices are probably the best example of stewardship, where we don't ever have to use an antibiotic at all. Using an antimicrobial that has no chance of working or no chance of impacting the clinical response for that bacterial disease is probably the worst stewardship practice we can have. So we got kind of both ends of the spectrum. And then over to the right, so this is things that we do after treatment has been administered to an animal. And you can do this both evaluation of our prevention practices and evaluation of our therapy practices. And this is something that I've added in, probably the most recent addition, but it's been several years yet, because this is what consumers expect from us, right? They want to know, they understand that animals will get sick. They understand that we have to use antimicrobials to treat those animals, but they want to know that we're getting better. And so what are we doing to make sure we're evaluating, if we had a disease outbreak that required use of antimicrobials, what failed? Was it our prevention practices that we need to go back and reevaluate? And maybe we need to change our nutrition program, and we need to add an additional vaccine program. Are our antimicrobial therapies working as we anticipate, and not just working, but also measuring our use? So I fully anticipate that at some point in the future, measuring antimicrobial use on farm within a system, I think that's a very real possibility for us. And so those are things that all in kind of encompass that definition of antimicrobial stewardship for me. So, and again, I work with a lot of veterinarians on the concept of antimicrobial stewardship, and some of the things that we have seen that are consistent themes in uh, why implementing stewardship is a challenge, or why enhancing stewardship in a very situation specific is a problem. And so, if we all kind of can roughly agree on a definition, so we're all talking about the same thing, usually the first hurdle is, well, is antimicrobial resistance even a problem? Because if it's not a problem, why do we worry about stewardship? And I have to think a little bit long term, and that's not it's not unusual for any type of stewardship. If we're talking about land stewardship or water stewardship, those are really long term thought processes. So it's not just, is antimicrobial resistance a problem today? Is it real? Is it a problem? And could it affect our use of these tools into the future? And so if we can say, and I'll most of the rest of my time with you today is really talking about that topic: is AMR a problem for us? And then the next hurdle is kind of, okay, so if antimicrobial resistance is a problem, then what is the risk of my individual actions contributing to AMR? So, and then I'm not going to talk about this because I don't have a great answer, and I don't know that anyone really does, and that's a huge challenge for us. And we'd like to say, we're in academia, we like to say, well, if we just had more science. Unfortunately, I don't know that science will ever completely answer this question. I think what we can generally say is that anytime we use an antimicrobial, there is the potential to select for antimicrobial resistance. And that's all I can really confidently tell you that I know is true. Um, Logically, I can kind of infer that, okay, so the more I use antimicrobials, probably the more pressure I create, but I really can't assign a specific. So if you were to ask me onto your farm and say, I do this, I use antimicrobials in this manner, all I could do is provide you some input on, okay, here are the things you might do if you wanted to decrease that use. Here are the things you might think about doing, but I can't give you that. So that's kind of the benefit side of the equation, but I can't really give you a specific number that you could assign to the risk. And that's what we get down to it. Stewardship is about. It's about balancing the benefit of using antimicrobials against the risk of antimicrobial resistance. And then the last hurdle is, okay, so if AMR is a problem, we'll get to that. Um, if my actions are contributing and to what extent, we can kind of relatively evaluate that. Then how much risk are you as the individual willing to take on to decrease that selection pressure? And we can think about that in a lot of different contexts, from a prescriber's context. So as a veterinarian, my risk is, if I said don't use antimicrobials in this situation, and it later came to light that my diagnosis was wrong and antimicrobials would have been of benefit, I didn't do my best service to you as a client. I may lose you as a client, so those are my risks. As producers, your risks are, if I don't treat this animal and it truly has a bacterial infection, that may be a loss of animal, it may be a loss of income. So all of these things become hurdles to how do we get to where we want to go with stewardship. But like you said, I'm going to focus really on that first hurdle today. Um, Couple different ways to kind of determine, is antimicrobial resistance a problem. I use this as kind of a guideline for what I do in animal health. But this was a report. It's actually the second version. They did an initial report, I believe it was in 2015, and then they came back and reevaluated this and published this in 2019. And it's really looking at the antimicrobial resistance issues in humans. So what are the big challenges that they have, and the way that they determine how, and they classify those risks as either urgent, serious, or concerning threats to antimicrobial resistance. And the way that they do that is they look at a bunch of different factors. They look at what's the clinical impact of that particular infection. So is it something that physicians commonly see, or is it a rare disease, right? And they look at the economic impacts, which I put that in there specifically because I think on the production animal side, we hear a lot about, we can't use economics to justify some of the things that we do, but certainly in human medicine, they are very concerned about the economic impact of antimicrobial resistance. And so how long a patient stays in the hospital because we aren't able to treat it effectively is a huge consideration for them. And then they look at the incidence, which is how common is that particular resistant mechanism in that particular type of infection. What's the projected incidence? So are we seeing more of those type of resistant infections or fewer? How transmissible is it? So is this something that affects an individual patient, or is this something that can be spread from patient to patient? And then they look at, what's the toolbox? What's the availability of effective antibiotics, of other effective antibiotics to treat that infection? And then how effective are their prevention barriers? And so they'll talk a lot. You've all been to a human hospital. You've probably seen posters about hand washing. You may see in some patient rooms reminders for medical staff to wear gloves and things like that. And they're trying to prevent those infections, those resistant infections, moving from one patient to the next. We have a similar document for animal health. The American Veterinary Medical Association, again, they put together a report, and they tried to use a similar methodology. I say they, it's we, I helped with this report as well. Tried to use a similar methodology to do that. Look at the clinical impacts, the economics, the incidence, the projected incidence, those kinds of things. It's much more difficult to do because we don't have access to the same data. So the Centers for Disease Control, they actually have access to patient records from hospitals across the United States, so they can actually pull that data out and have hard numbers to look at. We don't have those kind of surveillance systems in veterinary medicine, and so although this document attempted to follow the same kind of methodology, I would a little bit of caution that it's somewhat expert opinion. Um, and one of the things for food animals that came out that we're going to talk about today. So the Pasteurella ACA there in cattle that's bolded, those are the pathogens that cause bovine respiratory disease. And so that's what we're going to talk about. And so I'm going to kind of follow that same methodology. And so if we talk about, what is the impact of antimicrobial resistance in bovine respiratory disease pathogens? And I think we would probably all agree that, if we had widespread resistance in those pathogens, that would be significant for us, right? Bovine respiratory disease is the most common bacterial challenge that we have in feeder cattle. It would be one of the top three in dairy calves. It would be one of the top five probably in adult dairy cows, and it would probably be in the top five again for cow calf operations, so calves on pasture. And so it's a huge impact if we get resistance in those pathogens. And the second point, what is our prospect for new antimicrobials for bovine respiratory disease? And I would say our prospects are very low. The last time that we have received a new class of antimicrobials, and we'll talk about drug classes here in a little bit, but the last time we had a new class of antimicrobials approved for use in bovine respiratory disease was 1974. We have some new products that have come along the line, but they have just been alterations of an existing class. And so we know that within a class, if we get resistance within a class, cross resistance is typically very high. And so, and I firmly believe that the only new antimicrobial we will probably get for use in food animals is one that is too toxic to ever be used in people, and the manufacturer can demonstrate that cross resistance to what is already used in human medicine is very, very low. And that in combination with um, the economic returns for antimicrobials are not high for pharmaceutical companies, and so a lot of that development has even slowed down considerably. So I think our prospect for getting new tools is really low. So we have to manage what we currently have to the best of our abilities. Now, I think we talk about vaccines and antibiotic alternatives. I think the prospects there are much better. Um, Currently, where we're at, we have vaccines for control of bovine respiratory disease. There is a lot of research efforts being targeted for antibiotic alternatives. Some of those, uh, the the research so far has not been overwhelmingly impressive. I think we've been a little bit spoiled because the traditional antibiotics that we use with are amazingly effective, and so to have the expectation that an antibiotic alternative is going to have the same impact at the same cost is probably not realistic. So, but I do think that we will see some of those, and it's probably not a complete substitution where we can take this new antibiotic alternative product and put it in just like we would use an antibiotic and expect the same results. I think it's probably it's going to be a combination of things to get to that same level of efficacy. And so, one of the other things that the CDC report looks at is, what's the availability of effective antibiotics. So let's talk about that a little bit. So in the U.S., antibiotics are labeled for bovine respiratory disease. Antibiotics are labeled for either control of bovine respiratory disease, and so when we talk about control uses, those are uh, metaphylaxis would be a common industry term, mass medication, things like that. It's where we're using antibiotics in a group setting where some of the animals may be showing signs of disease, some of them aren't, but we're treating everyone. And so in the US, we have 9 products that are labeled for control of bovine respiratory disease. 9 antimicrobial products are labeled for BRD, um, which sounds like a pretty good toolbox, right? Like we've got some options here, but actually we have or we're limited to 5 classes. So numbers 2 and 3, so danofloxacin and enrofloxacin, those 2 drugs are in the same class of antibiotic. And when we look at data here, so I formerly worked in the diagnostic lab data where we would test bacterial isolates to their susceptibility to these drugs. When we look at those within BRD pathogens, if it is resistant to one of those drugs, 99.9% of the time it will be resistant to one of the other ones. Numbers 6 through 9, those are also in the same class. So those are drugs that would be in the macrolide class. And I'm sorry, I didn't put brand names up here. We would have Zactran, Zaprevo, Micatil, Draxin. Those are probably names that you've heard of. We know that within this class, we don't see quite as high of cross resistance, but it's still 75+%. So if I have an isolate that's resistant to one of those, 75% of the time it will be resistant to all of them. And so, it sounds like we have a lot of options for controlling BRD, but if we get into situations where we experience significant resistance, our toolbox can get smaller much, much faster. For treatment, so kind of the same situation for treatment, we actually have 17 different, and these are drug products. There certainly, for some of these, there are multiple generics, but it's the same from a bacterial perspective. It's the same chemical structure. It's the same molecule. For instance, number 17, that's Draxin. There have been 3 or 4 antimicrobial generic products that have now come on the market. Like you said, from the bacteria side, if it's resistant to one of those, it's resistant to all the generics, and there's strong resistance within that class. So you can see here, we have 17 products. I've grouped them by classes just to kind of see how they all fit in. And so you can see we have approximately 8 classes of antimicrobials that we have available to us for treatment of BRD in the US. So, we have a reasonable toolbox compared to some other things. Especially when we get into, things like small ruminants. There are very few products labeled for those. Swine, there are few products labeled primarily for respiratory disease there. So overall, it's a good toolbox. But again, because of the class effect when we see with antimicrobial resistance, it certainly can get smaller relatively rapidly. So so I'm about 30 minutes in here. So let's talk about what I wanted to talk about, which is the incidence and that projected incidence of AMR. So do we have an AMR, antimicrobial resistance issue, in the pathogens that cause bovine respiratory disease? And how I'm going to answer this question, again, I worked in the diagnostic lab here at Kansas State for 10 years. I saw a lot of this data come across my desk. Talked to a lot of veterinarians and producers that were facing these challenges. So this is kind of what I'm going to share with you today. And I want to start with just some caveats, because this data it's not like a random surveillance. We didn't go out and randomly pick animals that we would test isolates for, which is what you would see if you wanted to do a true surveillance program. If you wanted to know what the incidence of resistance in one of these bacteria was, you would need to go out and do that. Samples that come into the diagnostic lab are not that. They are, well, for us, we have a geographic bias, right? We do get samples from across the United States, but most of the samples in this data set are going to be limited to Kansas and kind of the surrounding states. There's a huge bias in which cases are selected. So most of these samples are likely coming from feed yards. They're likely coming from animals that died. I'm assuming of respiratory disease, and I'll tell you why in a second. And they're probably coming from animals that received multiple antimicrobials. And we know there's some other research out there that shows that if you test bacterial isolates from animals that have been exposed to antibiotics, you will see more resistant isolates. And the more antibiotics they receive, the more resistant isolates you will find. And so I just say that because, again, when you see the data, it can be a little bit striking. I will say that what you're seeing here probably is an overestimate of resistance. And there's probably, if you're a cow calf producer in the Southeast United States, I don't know that you would see the same patterns if you went out and sampled animals. My guess is you probably wouldn't. If you're a dairy calf ranch producer, in the western half of the United States, I don't know that you would see the same pattern of resistance. So again, just take it with a bit of grain of salt. Um, and again, all of these things play into it does have an effect on the data. And so what this is, like I said, it's not a true surveillance. Really, what it is it's just an analysis of our records. So we go in and we can go in and pull all of our diagnostic records. So what we do here is we look at any sample where the veterinarian requested a susceptibility test. And so that's the test that we do where we measure the effectiveness of these antibiotics against these bacterial isolates. I only look at bacterial isolates that caused bovine respiratory disease. That's all I'm going to show you today, right? So that would be Histophilus, Mannheimia, and Pasteurella. I didn't include Mycoplasma bovis. If you're interested in Mycoplasma bovis, I'm sorry I don't have that data for you because we don't have a standard method. There's no agreement on how we should test Mycoplasma bovis for susceptibility to antibiotics. And so I only look at cases that are from bovine lung. And again, my assumption is that if a veterinarian is sending in a lung sample and we are growing one of these bacteria, there's at least a possibility that that was a respiratory case. So I don't really, I'm not, the history I get isn't always indicative that, yes, this was a respiratory disease case, but that's my assumption. I think it's probably a pretty good one. So I'm going to show you the data from 2010 through 2018. I've actually looked at it more recently than that, but COVID had a pretty severe impact on the number of cases that we have seen over the last few years. It's starting to come back, but the numbers of cases were really low. The numbers of isolates were even lower, and so my ability, one or two isolates makes a huge difference in the percent susceptible. So I didn't include that. And then I'm going to show you these 6 drugs, and really these are class representatives. Again, we test more than this, but that keeps the data from looking funny because we have these class effects. And so what you're going to see, so you can see this table just kind of gives you a big picture view of, so what, how much are, how many isolates are you seeing? How comfortable are you with the data? My answer is I'm pretty comfortable. There's a lot of isolates here. If you look at um, other publications of this type of data, sometimes they have as low as 30 isolates, where for some of this we have several hundred isolates. So I feel pretty good about it. If you look at Histophilus over here to the far right, um, Histophilus is a bacteria. It's a little bit harder to grow, and it probably doesn't survive transport from the field as well, from the field to the lab as well. So I think we probably lose a few of those isolates. For a Histophilus conclusions, I still feel pretty comfortable with that. The last, 2018, we saw a little drop off, so I interpret that a little bit cautiously, but okay, so what I'm going to do is I'm going to show you for Mannheimia. We'll start with Mannheimia. What I'm going to show you is I'm going to show you charts, and I'll just flip to the next one because this is the example. So what you see is each bar is the year, right? So we have 2010 through 2018, and then the percent of all isolates, and then so green is susceptible. And I didn't think about if you're colorblind, that's the bottom bar. And then intermediate, so that's intermediate susceptibility. That's the yellow bar on the stack. That's the next level up. And then the percentage of isolates that are resistant to that drug are the top part of that stack bar in the red. And so you can see for this particular drug, for enrofloxacin, that's its brand name is Baytril. You can see it varies a little bit year to year, but about 40% of our isolates, 50 to 60%, somewhere 40 to 50%, year to year will be resistant to enrofloxacin. And that means we think that it's likely to not have the positive clinical outcome that we're after. So I'm going to go through the others 5 drugs fairly quickly. The graphs are all laid out the same. It's the percentage of isolates that are susceptible, intermediate, and resistant by year, because the pattern is very, very similar. So for fluorophenocal, a little bit overall, I'd say a little bit here. We average probably closer to that 30-40% of isolates in any given year are resistant. For oxytetracycline, and again, here we see a much higher percent. So 70+% of the isolates year to year are resistant to oxytetracycline. And that kind of makes sense from a couple reasons. One, oxytetracycline is a drug. It's a little bit older. We've used it more, in it, and not just oxytetracycline. So that would be like biomycin or LA200, but it's also in the same class as chlortetracycline, which is one of the two drugs that are the highest use as far as feed grade antibiotics go. And so there's a lot of selection pressure against this particular drug or drug class. The other thing, from the bacterial perspective, there are hundreds of different resistance genes to the tetracycline class, and so it's just a much more common resistance mechanism when we go out there and look. Penicillin, roughly year to year, 40 to 50% of the isolates are resistant. Spectinomycin. I used to say this graph didn't matter because we had a spectinomycin product that was labeled, but it wasn't marketed for a long, long time. They've actually there's a new generic of this product that's now available and labeled for respiratory disease. So this might be something that somebody's thinking about employing because it's a quote unquote new. It's actually a re-release of an old antimicrobial product. Again, 50% of our isolates year to year would be resistant to that particular class. And then I use telathromycin or the Draxin as the marker for the macrolide. It's would include all of the Zuprevo, the Zactrian, Micatil, all the generics of Draxin, the Increxes, whatever is out there. And again, year to year, we see a little more variability here, but 50 to 60% of our isolates are resistant to this class. So from a from a resistance perspective, we see isolates that are resistant, very resistant to the antibiotics that are available to us. So, but we go back to, we have this huge toolbox that we can dip into, right? And if it's resistant to one of those, we'll just go on and move to the next antimicrobial in our protocol. The challenge is that, and you can probably deduce this a little bit, because the isolates, because there's such a high percentage of isolates that are resistant to each of the individual drugs, and what you would expect is many of those isolates are the same. And so what we are seeing, particularly for Mannheimia, is that if an isolate is resistant to multiple antimicrobial products at the same time. So what you see in this graph, again, the percent resistant is here on the vertical axis. And then the years you can see over here on kind of the axis that goes into the screen. What you see here on the horizontal axis, this 0 through 7, that's the number of antimicrobials that an individual, so if I look at this from the individual bacterial isolate, that's the number of drug classes that bacteria is resistant to. And so if you look at, I don't know if you can see my pointer or not, but this series here to the far left at 0, that would be bacterial isolates that are resistant to 0 antibiotics, or the way we say that, those are pan susceptible. We think every antimicrobial would be a reasonable choice for that bacterial infection. And then as I move to the right, there's isolates are resistant to 1, 2, 3, and then we see this series over here to the far right at 6, where those are bacterial isolates that are resistant to 6 of the 7 antimicrobial classes that we tested. So really, really limits um, our toolbox quite a bit. And the table at the bottom is the same information. It's just kind of grouped. You will often hear the words multi-drug resistant, or extensively, or some people say extremely, but extensively drug resistant. It just summarizes those. So multi-drug resistant, those percentages would be everything, including the 3 column all the way to the right. And the extremely drug resistant would be just the 6 and the 7, although there aren't many isolates over there in the 7. It would be a cumulative summary of everything that's in that 6 and 7 column. So that's Mannheimia. And so again, the picture is a little bit bleak there. And I just was at a conference with a bunch of human physicians and some veterinarians, and they were kind of asking questions in relation to, you know, do these patterns, are those indicative of poor stewardship practices. And I said, no, I don't think so. I think what it is indicative of is it's the biology of what bacteria are able to do and adapt when you put antimicrobial selection pressure on. And I actually use the next few slides to support my point, which is if if the patterns that we saw with antimicrobial resistance were simply just a reflection of poor stewardship practices, then we should see the same types of patterns with other bacteria, right? Because when we are treating BRD cases, usually at the time of treatment, we aren't differentiating, oh, this is a Mannheimia case and this is a Pasteurella and this is a Histophilus. And so the bacteria, whether it's Mannheimia, Pasteurella, Histophilus, should be seeing the same drug selection pressure, and I would expect the patterns to look very similar when in fact they aren't. And so I'm not going to show you the individual drugs for Pasteurella multocida because, and thankfully, they're actually quite boring. Most of the isolates that we see are susceptible to most of the drugs that we test. You can see here in the graph, 60 to 70% of the isolates were pan susceptible. They were susceptible to all the drugs that we tested. And then there's this kind of sprinkling effect of, there are a few isolates that are resistant to 1, 2, or 3. That's most of them. And those drugs are typically, you'll see a mix, and they're not always the same ones, but tetracycline, we see high levels of resistance to tetracyclines. And again, for the same reasons, it's a drug that's been used clinically for a long time. We have a lot of pressure because of other drugs in that class that are being used. So, but from a treatment, from a veterinarian perspective, I look at this and they say, I still feel like I have tools at my disposal to treat infections caused by Pasteurella. And then Histophilus, and I'm sorry, the graph changed a little bit. I had some issues with Excel, but it's kind of a similar story as Pasteurella. We see fewer pan susceptible isolates. We see more Histophilus that are resistant to 1, 2, or 3 antimicrobials, but we don't see that very dramatic pattern like we do with Mannheimia, where it's kind of an all or nothing response, where they're either susceptible to everything or they're resistant to everything. And we think with going back to Mannheimia and that all or nothing pattern, there's been a resistance mechanism that's been described in the literature. It's kind of, I don't know if you're familiar with a plasmid. It's like a plasmid, but it's a package of antimicrobial resistance genes that all move together, and we think that that's probably why we see that dramatic pattern in Mannheimia. And what that means is that if you have resistance to all of those antibiotics, using one of them will promote resistance to all the others because there's now a selection pressure for that element. But with Pasteurella and Histophilus, again, we don't see those same patterns. We do see resistance, but it's typically 1 or 2, sometimes 3 antimicrobials. Still gives us effective tools. Still think we can move forward with the drugs that we have. So I just kind of want to sum up real quick. So, antibiotic resistance isn't just about drug use. It is. So we need to be concerned about what is the selection pressure we're applying, because that affects our ability to use those drugs to treat infections in the immediate future, but also in the long future. But it's also about the bacterial population, right? If I have a completely susceptible bacterial population and I choose the right drug, in theory, I can clear that infection and that there's no resistance that gets propagated. And so it's more than just about drug selection. um, I am very convinced that, when we talk about is antimicrobial resistance in BRD pathogens real, I think that is real. And this is certainly not the only report of similar kinds of data in the literature. There are other people that have independently reported this kind of phenomenon where they're seeing high levels of resistance to multiple antimicrobials. um, if you, and I don't know if I didn't point it out specifically, but if you kind of look at those charts, the last few years, it appears that that trend of multi-drug resistance is fairly stable. It's kind of stabilized at that, 50 to 60% for most of the antimicrobials. Just a little bit of caution with that. I do, you know, these trends are all affected by what kind of samples were received in the lab. And so if a veterinarian sees a lot of reports that are resistant to everything and they decide to stop submitting samples because they're resistant to everything, then we've essentially lost that data. We don't see that data anymore. And so it kind of that there's a huge submission effect as far as trends go. So I interpret that very cautiously. But then also, just kind of as a last point, that not all the BR, when we talk about resistance in BRD pathogens, we kind of, that's how we talk about, we say resistance to BRD pathogens, but the individual bacteria are quite different in the challenges that they pose to us. So I kind of insert that as a last word. We really need to be talking about what are those specific challenges that we have and how do we address those challenges. So I've got one slide and then I'll take some questions, but I just want to show you this because I think it's really hard for us, everyone on this webinar, and unless you're really, really old, um, has not lived the majority of their life without antimicrobials. We've all lived in the antibiotic era. And so this was a prescription. It was sent to me from someone in Kansas. They just randomly sent it to the vet school, thought somebody might be interested in it. And it ended up on my desk. And the person estimated that she was cleaning out her grandfather's farmhouse, where this was located. The other paper, she thought it was probably from around 1920. And this is a prescription for diarrhea in chickens. And I don't know if you can read that, but it says tincture of nutmeg, tincture of ginger, and tincture of iron. And I don't know, if I think about nutmeg and ginger and chicken, that's a recipe, not a prescription. But what I don't want us to get to is this. I don't want to go back to these days where we don't have effective antimicrobials. And so I appreciate everything you guys already do as far as antibiotic stewardship. Antibiotic stewardship you're doing. I would encourage you to keep thinking about ways that you can improve that on your individual operations. And so, again, thanks. And I see there are some questions in the chat box, so I would be happy to take a few of those in the time we have left.
Thank you, Dr. Luber, so much for sharing your insight and outlook on this very critical topic that affects producers, academia, consumers. It affects everybody in the beef supply chain. And I know I'm not alone when I say that your words were thought-provoking and encouraging. So yes, we do have quite a few questions. So we'll just start going down the list here. So one of the questions is that how can we ensure that animals receive appropriate medical care while also reducing the risk of antibiotic resistance? How do we find a balance there?
Yep. That's a great question. And so, and again, we all approach this a little bit differently, right? And that's why I start with that definition of stewardship. We all kind of have different takes on this. For me, and one of the things that I see in the research community is kind of a re-emphasis and a refocus on diagnostics. And again, that's my particular slant too. So, but really what diagnostics tests, and the ones we have now, are challenging because the turnaround time, you collect a sample, you send it to the lab, 3 days later, you get a result. Well, the outcome for that animal has already been the outcome, whatever it was going to be by that time. And so really the focus is on point of care diagnostics. And what that does for us is it helps us reduce the uncertainty with the diagnosis. So if we have a test that can help us say, yes, this is BRD, or even better, a test that says it's BRD caused by this particular pathogen. And we talked about BRD, but that relates to you can pick any disease challenge in animal health that you want, and you still have the same situation. If we can find those tools that help us differentiate, either this is the disease condition that we're dealing with and antibiotics are appropriate. And I get very little resistance from consumers that when an animal gets sick, antibiotics aren't, with a bacterial infection, antibiotics aren't appropriate. I don't get pushback for that. Hello?
I
Randy?
was agreeing with you. Go ahead.
Oh, okay. Okay. Sorry. Yeah. Yeah. So I think it's about things that we do so we can be like, okay, we have tools that help us determine this is the case that needs antibiotics. Or it might be a tool that says this is an animal, we know it's sick, but the probability of a response is not good in this animal and we need to make a different management decision. So I think telling those stories about, hey, these are the tools of technology we use to increase our diagnostic accuracy. And the other thing goes back to what I said with my definition of stewardship is really talking about our management practices, our prevention practices, the things that we do. We have this picture on the screen right here. If we have a typical scenario, the BRD morbidity in that pen of calves, well, that pen specifically, probably not, but a pen of feedlot calves is probably in that 10% range, 10 to 15%. Obviously, we have more extreme and we have less extreme, but let's just say, 10%. What we're telling the consumer is 10% of these animals are going to get sick with a bacterial infection. We are doing these things, X, Y, and Z, to prevent that disease and keep that number as low as possible. But when we get to that 10%, we're also doing A, B, and C as far as testing goes to determine that this is an animal that truly needs an antibiotic and it's an animal that we think will have a favorable response. And I think that's where we're at now. I think that's the best we can do. Um, Maybe something will come along that's groundbreaking in the future that changes that, but I think that's the balance. So, well, I could probably ramble for another half hour, but we got other questions, right, Brandy?
It's okay. It's okay. No, it's good information. It's a complex topic. There's not a simple answer for that. So it's absolutely, this is the kind of discussion we want to have. So that was a great question. Our next question is, as newer antibiotics are used more commonly than those used years ago, do we see any regression of resistance as they get used less often?
Yeah, and I think sorry, I'm looking at the question. I think that's similar to question number 4. So they ask a similar question about, is it possible that, if we sunset certain antibiotic classes, would we gain some efficacy back? So um, I will. So there is actually that actually is a practice on the human side. They have
Okay.
tried to do that, and specifically like in ICU units where they are experiencing resistance challenges. They will actually try, if it's to a particular drug, they will take it out of the formulary and see if they can regain the efficacy. Okay, um, and and it's marginally to almost not effective is how I would kind of summarize the what they've found with that. I will say particularly for Mannheimia, so the example I showed you, because if you have that resistance element, it's called an ICE, an integrative conjugate element, that carries resistance to all the classes of antimicrobials we use. It doesn't matter which one you sunset, because if you choose another antibiotic, we still are applying a pressure for that particular bacteria, which has that particular resistance package. And as soon as you go back to the one you've sunset, the resistance is still there in low levels. So, and that's kind of been the experience in the human ICU units where they've cycled antibiotics, they've taken them out of the formulary and brought them back, is that you will see it if you do surveillance, you might see resistance go down a little bit. But as soon as you re-implement that antimicrobial into the formulary, it comes back very rapidly. So it's probably not an effective long-term strategy for us, unfortunately.
Okay. Thank you for that insight. I didn't know that that was a practice on the human health side. Um, our next question is, what should we expect in terms of treatment, development, and research for BRD considering AMR?
Oh man. Um, so I mean, I think, and it's BRD research can be a little frustrating because we've been doing it for like 40 or 50 years. And some days I feel like we haven't moved the needle very much at all. But I do think what I see um, are I guess I'll kind of break those areas down, because I think when you talk about treatment specifically, so antimicrobial therapy for BRD, um, again, I think we're all fairly convinced we're not going to we are past the golden age of antimicrobial discovery for specifically for veterinary application. We're not going to be getting new products every year. That's not happening. So I think for treatment, we're seeing more research on how do we how do we use the tools we have better. And so we our research group specifically, we have a strong interest in durations. So for injectable products for BRD, many of those are labeled for single injection, and so you
Mhm.
administer them once, and they have durations of therapy that range from a couple days to like 10 days, right? And we have very little control over that. But there are some of those products, and some of the feed products like chlorotetracycline, we have control. And so I think doing some research to look at what's the optimal dose, the duration of dosing for this particular product. How do we get the maximal effect with the minimal exposure? And then the logical extension is, with minimal exposure comes minimal selection pressure for resistance. Um, development research. So research, where there's always the continual research for a better vaccine, a more effective vaccine. I think timing of vaccine, we're learning a lot about bovine immune responses and how probably best to adapt those. Um, Again, diagnostics is a big thing. So looking for those point of care tools that help us differentiate which animals need therapy, which animals don't need therapy, and which animals may not respond despite therapy. And then, I mean, there is a huge amount of work going into alternatives. I can be a little bit of a pessimist in that area, so I'll try to temper that a bit. But like I said, we've been so spoiled with the efficacy of traditional small molecule antimicrobials to have a magic bullet that's going to show up. I guess I'm a little hesitant to say that. But I do think there's products have some promise, and it's going to be a matter of if we are inventive enough to find where and when they need to be applied to get the right effect from them.
Okay.
Hopefully that answered your question. That's a huge one. So
That's okay. Again, these are not simple questions. There
no.
are no black and white answers. Well, I don't see any other questions from the audience, so I think that might be it. Again, Dr. Lubbers, thank you once again for your excellent presentation, for being here with us today. You've done a great job of gathering our very relevant and timely information about antibiotic stewardship and sharing that, and we are very grateful for your contribution. On behalf of the Wisenetics team, I'd like to thank everyone for attending and participating in today's webinar. Many thanks to the people who are backstage working the knobs and buttons as well, who always contribute to the dissemination of quality content on the Beef Podcast Show. To wrap it up, I invite you to follow the Beef Podcast Show on wherever you get your podcasts, as well as follow on Instagram and Facebook and the Beef Podcast Show. And the link to the show's website is available here in the chat. Dr. Lubbers, do you have any final message for our participants?
Just I think tell your story and work with the veterinarian, do the best you can, and keep moving us forward.
Great. Well, that's a great way to end it. So until next time, everyone, thank you and have a good day.